Hello, everybody, and welcome to the Hughes Clues Burn Trauma Student Success Review session. And when we talk about burn trauma, because it is a traumatic injury, we are going to use the trauma assessment technique, which begins with the primary survey, ABCDE, and then, of course, the secondary survey. And so these are all the details of primary and secondary survey. This is especially important for you to understand as we go through the questions, especially if you haven't looked at the trauma scenario. Every semester has a different order of material approach. And so if you've already seen this, then this looks very familiar to you. And I'm just going to remind you that burn trauma is really trauma, and therefore that's the system that you use to assess a patient. And when we talk about patient assessment, we all know with the ABC method, and then of course we've added D in this semester. And this table I think is very helpful to kind of give you an idea of what things or what nursing actions are involved in assessment of an airway. So you can see on this side of the table that's what that addresses. And then there are what are the nursing interventions that are done in association with airway management. And then we have breathing, assessment and intervention, circulation assessment and intervention, and then disability assessment and intervention. So I think this is very helpful, not only for the critical care test, but for ATI and NCLEX, so that you kind of get a sense of when you're asked a question, what's the most important or immediate or initial action by the nurse, then ABC should come to mind. Let's do some scenarios where we've got a client that's brought to the emergency department with partial thickness burns to the face, neck, arms, and chest after trying to put out a car file. The nurse should implement which nursing actions for this client, and I've got to select all that apply. Again, in Canvas, it will look a little bit different. There would be all of these actions, or a few of the correct answers. Actions would be on one answer choice, and then there's going to be three answer choices that are going to encompass incorrect and correct options. So you really have to look at each one of the options to make sure that they're all correct before selecting that answer choice. So if you want to pause the recording and figure out which actions are associated with the nursing interventions for a client with burns, and you should have identified that B, because that's pretty much what we do for every patient, assess the airway patency, administer oxygen if it's prescribed or if it's needed. Sometimes the nurse independently kind of does this in critical care, not so in NCLEX and ATI because the nurse can't do a lot of independent actions. But if it's ordered, as it says here, then it's an appropriate action. And then the last thing that should be done is to elevate the extremities if no fractures are present. And again, why not elevate extremities if fractures are present? Well, again, it's obviously making sure that we don't move around fractures. That was listed in the trauma as a cause for a fat embolization. It's mostly if they're open fractures. But anyway, if they're not fractured, then this makes it easy. You should elevate. Now, why aren't the other options correct? Well, I think everybody can identify that with burn trauma, we know that burns will require a lot of fluid resuscitation, so we're not going to restrict fluids. We're going to do the opposite. We're going to give a lot of fluids. Well, why not place a cooling blanket on the client? So the purpose of this being a wrong answer is to remind you that the skin is responsible for thermoregulation. And when you have a loss of skin because of a burn, then there is problems with thermoregulation. So these patients can be hypothermic. That's one reason. Another reason is that if you put a cooling blanket on the skin, it can cause vasoconstriction. And so we really don't want to do that because we don't want there to be enough of vasoconstriction to cause ischemia. So that's a twofold reason why answer D is the wrong answer. And then the last one, prepare to give oral pain medication as prescribed, is an incorrect answer. Why? Well, because we know that individuals with burns and traumatic injuries in general do have hypomotility of the GI system. And so oral medication is not given. We should give it an IV route. IM medications are also not given because there is or can be a problem with the absorption of the medication in the IM route, because if you have a markedly burned individual, then there could be some vasoconstriction just because of the physiologic response of the body after a burn, and so you wouldn't want to give it IM, or you wouldn't want to give it oral. You really do want to give all medications the IV push route. During early burn trauma care, patients are at greatest risk for complications related to. All right, with this answer choice, again, hopefully this is very easy. Really, the most common priority action or problem is the fact that there is altered capillary permeability, which means that there's a whole lot of leaking. Things are moving from the vascular space into the tissue space, and therefore there is a lot of fluid that is lost, and in addition, proteins will also move from the capillary or the blood space into the tissue space. So that's the greatest complication. With all questions that ask you about the greatest risk, it should relay to you that, you know what, these other answer choices are correct. And I don't think sylvadene toxicity, that's your one outlier that's like dumb, and so you would know not to pick it. But the other three, B, C, and D, well, they're all problems that occur with a burn. And again, you have to think of greatest risk. So what is the most problematic problem for your patients with burn? And that's that capillary permeability and leaking. Iatrogenic infections do occur. We do have to do interventions so that they don't happen, but it's not the greatest risk. Curling's ulcer is also a risk, but it's not the greatest risk. A patient who received 27% total body surface area burn in a house fire was admitted to the burn unit, which finding is the most sensitive early indicator of an inhalation injury. And when we look at this, in the question, the most key thing is the most sensitive early indicator. So this means that the problem or airway problem is present. So when you have a patient, the answer to this question, who has a hoarse voice, that's the correct answer, that is an indicator of an actual inhalation injury. If you thought about picking singed eyebrows, which is a wrong answer, but you thought, well, wait a minute, singed eyebrows, that means that fire or flash burn was close enough to cause burning of the hair of the eyebrows and or nasal hair, that represents a potential. So yes, you, the nurse, have to assess and make sure that the airway is open, that it's patent and not edematous, because it's a potential, but it's not an actual. So that's why answer A is the correct answer. Now, if you thought about cyanotic or lethargy, those are correct, as in they would be an indicator of an inhalation injury and poor oxygenation or elevated CO2 retention, but they're not early. They're late. And if you wait until your patient has cyanosis or lethargy, then you've really missed the party for your patient. So don't wait. You want to do the early indicators. So what else might it be? Well, if it was hoarse voice, obviously that's one we've talked about. That represents that there's edema. But if there's what's known as stridor is where the patient will inhale and there'll be this high-pitched noise. That is an indicator of upper airway problems, upper airway restriction. Or it could be that it's muffled or the voice sounds weird. So there could be all kinds of descriptors for actual airway management issues, and you just need to be on the lookout. Drooling is another indicator that the patient can't swallow. So these are things that indicate an actual airway problem. An 80-kilogram patient involved in a house fire is admitted to the emergency department with burns to the right arm, anterior trunk, and right leg. And then with this scenario, I'm going to ask you three different questions. The first one being calculate the burn body surface area. The second one, how much IV fluid should be infused in the first 8 hours. And then the third is how much IV fluid should be administered per hour in the second 16 hours. So let's address each one of these questions one at a time. So we're going to do first, calculate the burn body surface area. And in our course, we calculate the burn body surface area by using the rule of 9. So you've got to put this picture down on your exam sheet so that you can see that if you do 2 stickmen, you've got half on each thing. I will tell you that a lot of students, when they put their stickman on their sheet, they like to just do want because that's less space that it takes up, and then they wind up having the body from the neck down, but for whatever reason they put 9% on the head. So don't do that. If you're going to do one stick man and have it, knowing full well that if Dr. Reed says the entire arm, that you're going to double it, do the same and keep it consistent, because in a test your brain doesn't work quite the same way. You're in a hurry, and so you don't want to make that mistake by saying, oh, well, that's 9% is half, especially if Dr. Reed asks the back of the head. Now, if she wants the whole head, she would just say head, or if she wants half, she would either say back of the head or face. So you got to be careful with some of the terms to make sure that you don't overestimate or get the wrong body surface area calculation. So there's our stick man. And so when we look at this, we have an 80-kilogram patient, and they had burns to the right arm, anterior trunk, and right leg. And so when we look at that, we know that the right arm means front and back, so that's 4.5 times 2, or 9%. The anterior trunk is going to just be 18%, and the entire leg, half, is 9%, so 2 is 18. And when you add 18 plus 18 plus 9, that comes up with a calculation of 45% total burn body surface area. So how much IV fluid should be infused in the first 8 hours for an individual who has 45% burn surface area? And when we look at that, we know that the formula for most burns is 2 mils per kilogram times the total body surface area. Notice how this fluid volume is divided up. You're going to give half in the first 8 hours and then the other half in the second 16 hours. So let's go back to our question, how much fluid should be infused in the first 8 hours? And so we look at the formula of 2 mils times 80 kilogram, that's what our patient in our scenario weighs, and then times 45, and that's the burn body surface area. Now don't think, well, 45% means when I multiply it should be a 0.45. No, that is incorrect. You want to do the full 45. We're not going to do proper math. We're going to do this burn math, and so it's a little bit different. So we have 2 times 80 times 45, and that gives you 7,200 mils in 24 hours. So if we're going to, and then we look at the question again and we see that we want to know how much in the first 8 hours. So you're going to divide 7,200 by 2 because half the total volume is going to be delivered in the 8 hours. So that means in the first 8 hours, we're going to give 3,600 mils of IV fluid. Our last question is how much IV fluid should be administered per hour in the second 16 hours. So let's look at that math. And we see that if we've already calculated that the patient needs 7,200 in 24 hours, and then half is given in the first 8 hours, which means 3,600 mils, and then we're in the second 16 hours, so we're going to give 3,600 mils is going to be given in the second 16 hours. Now that's not the answer. Wait, the question asks how much per hour. So if we know that this 3,600 mils has to be given in 16 hours, we're going to divide 16 by 3,600, and that's going to give us 225 mils per hour. Now, the math on burn calculation is easy as pie. You've done this so many times. But what gets students is the trickery. So make sure you read the question. Are you being asked which portion of the day are you being asked about? Are you asked the total mils? Or are you being asked how much are you going to set a pump? Or how much is going to be given per hour? So just be careful. An 80-kilogram patient who sustained major burns needs a large volume of IV fluids in the initial 24 hours. So which additional assessment finding would indicate successful fluid resuscitation? So when we look at all these answer choices, we know that the patient's 80 kilograms, and we know that per our rule, whether it was in the shock scenario or the kidney scenario or the trauma scenario, the minimum amount that an 80-kilogram patient should put out or have urine output is 40 mils per hour. And that's what's going to indicate to you, the nurse, that successful fluid resuscitation has been obtained. If the urine output is 30 mils, that's not enough. Now, I know that a lot of us know that in the hospital setting and often in previous courses that we've learned that 30 moles per hour is a successful amount. It's really not. And individuals who use that 30 mil per hour for every patient are really kind of old school. Now, I'm not saying that it's not done. It is done, and I've seen it a lot. But per the actually Kidney Foundation, it is 0.5 to 1 mils per kilogram. Could this be 60 mils per hour? Sure. It can be anything over half a mil per kilogram, even 1 mil, greater than 1 mil per kilogram. I mean, if your patient was putting out 80 mils per hour, you would go, yo, that patient's doing great. So it has to be just a minimum of 0.5 mils per kg per hour. So that's why C is the answer and B is not the answer. Well, what about a CVP of 5? If the normal CVP is 2 to 8, isn't that close? Well, we really don't know. The best indicator of what we've learned in many, many different scenarios, in the shock scenarios and trauma scenarios and kidney scenarios, is that half a mil per kilogram is the minimum. 1 mil is even better. And that's really what tells us that the patient's been adequately fluid resuscitated. Now, for some patients, it may mean that fluid resuscitation may be good at 5 mils, but the urine output is technically the window into the body. And so if the kidneys are perfused, then the body has enough fluid. So that's why these other A and D are not correct. An 80-kilogram patient presents with major burns to the face and body. He's intubated on arrival, placed on mechanical ventilation. He's been resuscitated with a large volume of valve fluid. So which additional assessment finding would cause the most concern for the nurse? So now we're looking at things that cause concern. In other words, we're answering the question backwards. We're saying, what would the nurse find concerning as opposed to what would the nurse find as good? So what would be a concern? Well, you would be concerned if your patient's CVP was 18. If 2 to 8 is normal, 18 is really high. And again, it's just a number. But when you hear crackles, that would indicate to you that, you know what, this patient is probably volume overloaded. And we know that in individuals who are elderly, even though we know that burn immobilization or mobilization of fluids and fluid movement to the third space is happens very quickly, and therefore they do need a large volume of fluid. We know that patients, especially if they're elderly, can have comorbidities such as heart failure, such as kidney problems, or some other problems. Even if they're healthy, they may have a problem with getting 3,600 or 3,500 mils of fluid in 8 hours. It may be just too much volume and they get overloaded. So you know, that would be the most concern. Urine output at 65, that's great. CVP of 12, well, that just might mean that the volume is high because of the fluid, a rapid amount of fluid infusion or fluid resuscitation. But as long as the kidneys are peeing, chances are the patient will do okay, that the CVP will go down. So, yes, you might be concerned about that. But it's really not a bad sign until your patient shows signs and symptoms of fluid overload, such as crackles, hemoptysis, complaining of dyspnea and shortness of breath. So these are the things that would be most concerning. The other things are not. Again, I think there was something in the notes that said the fluid volume resuscitation is going to vary from patient to patient, and just remember that. It can be a little bit more than what is normal or what is the normal formula, or it can be a little bit less that is needed. So it's really about you, the nurse, assessing the patient. An 80-year-old patient presents with major burns to the face and body. He's intubated and placed on mechanical ventilation, but now the high pressure alarm keeps sounding. So which additional assessment should the nurse perform? And the answer is check for secretions and auscultate the lungs. We've already talked about the fact that a lot of fluid can present with volume overload. So either this patient has a lot of secretions and that's what's setting off the high pressure alarm, or perhaps this patient is becoming volume overloaded. But either way, the high pressure alarm will go off when there's resistance in the lungs. This is kind of a reminder for the final exam. You're not going to be asked about the ventilator alarm going off. You will be on the final exam. So check for secretions, auscultate the lungs is the correct answer. The other, determine if the connection on the ventilator is loose. That is not correct. And of course, you should always be cautious about selecting an answer that says the nurse should turn off the alarm. Now, I've seen it on different questions where it's been silence the alarm. So silence the alarm, I think, could be okay, because it could mean that the nurse walks in, assesses the situation, and then makes the noise go away. But it also could mean that you're completely turning off sound. So you have to be careful when you see the phrase turn off the alarm or silence the alarm, because the nurse would never ever want to completely disarm the alarms on the monitor. That's always going to be wrong on a standardized test and potentially on Dr. Reed's exam. So you're going to have to be cautious about picking that answer choice. Is it okay to silence an alarm? Sure. After you've assessed the situation, you can turn the sound on as long as you don't permanently disable it, because alarms have to be on according to JCAHO. And I know this is kind of a confusing thought, because there's probably been each one of us that have seen a nurse actually disable an alarm. You can't do it on a test, that's for sure. So be careful, be cautious when picking that answer choice. Again, the point of this question was not so much about ventilators, though I did really address ventilators a little bit more. The question is about the complications that can occur, not only with burns in general, but with rapid fluid volume resuscitation. I want you to remember that ARDS can occur. And so I've kind of got a bunch of reminder information about what would classify as an ARDS diagnosis. Pulmonary infiltrates, which just means water in the alveoli, which would be evidenced on assessment with RALs or crackles, hypoxemia despite increased O2 delivery, and then the high ventilator pressure. So I do want you to remember that ARDS is on the list of complications that can occur with burn trauma. In the event of a tar burn, which immediate action should the nurse perform? Select all that apply. Now, you're not going to be asked on the exam about specific substances. It's really a general action. So this could have been hot grease, this could have been butter, this could have been a hot plate. It could be anything. You really want to ensure that you cool the injury with tap water. You want to flush or irrigate. And you want to ensure that if the clothing had been splattered with a lot of, say, hot grease, say it was a Taco Bell employee and they were changing out hot oil or something happened, well, you would want to remove any hot solution saturated clothing, because the patient's skin is going to continue to burn. So the answer to this question is A and D. You do not want to remove adherent clothing, because you don't want to rip off skin, because that can cause problems for the patient, and you don't want to worry about removing the tar from the injury, because again, you're going to be peeling off what's tar is attached to, which is skin. So again, do not worry about specific substances or items. This is really about the general. If there's a solution, a substance that's hot, and it's on the patient's clothing, get that clothing off so they don't continue to have burns from the hot whatever it is, and then also to keep cooling the injury with water. Exposure to a dry caustic chemical has caused a hand burn. Which intervention is appropriate in the emergency care of this patient? So the key thing to you is irrigate with copious amounts of tap water, not iced water, just plain old tap water. And so there may be, again, some specific information that was provided by the burn lecturer, the Stephanie Campbell, the burn nurse, that's a specialist. And we know that perhaps you would brush off the chemical, but then you've still got to irrigate, because whatever is on the skin has to be removed. And so that's why you see in the hospital setting, if you haven't noticed this, go back and look the next time you're in the clinical area, and you'll see that there is always an irrigant little water bottle that is present so that you can irrigate eyes or stick your hand under there, but you do want to irrigate. The nurse is developing a care plan for a client with a circumferential burn injury of the extremities. The client problem states ineffective tissue perfusion, so which nursing intervention should the nurse include in the plan of care? Anytime there is anything that is mentioned as a circumferential injury, it doesn't matter whether it's a burn or it's a traumatic injury, the bottom line is you have to assess for perfusion, and that's by pulses. Does the patient complain of paresthesias, which is kind of tingling and burning? Is there a lot of edema? Is there a diminished pulse? So these are the things that you really want to assess for. So what is this related to? Well, it's the 5 Ps. So the 5 Ps assessment are ensure that there's a pulse, make sure that there is a good, the skin is warm and dry, there's a good temperature, that's poikilothermia, you don't want it to be cool. Paresthesia, pain that's beyond what is expected. In other words, they seem to keep asking for more and more pain medication, and the pain medication is not managing it. And then, of course, paralysis. Paralysis and pulselessness are late and ominous signs. While working on a power line, a person experienced a high voltage electrical injury. The primary nurse or the primary survey has been completed. Emergency management will likely be on injuries to the, and the answer is heart and spine. So, I get this is kind of a dumb question because some of the things perhaps overlap, but I really basically want to make sure that you pay attention to the fact that when a person is up high and they fall, that spine is part of airway management. So it goes very, very high on the priority. Now, once the spine has been immobilized, either with a C-collar and or a backboard, then you're good to move on down to B and C. And the reason why heart is there is because that any kind of electrical injury, because it is electrical current has passed through the body, places the patient at risk for dysrhythmias. So you do have to be very, very aware of the problems with heart and spine. Now, is muscles a problem? Well, sure it is, and we'll talk about why that is later. But I get kind of a dumb question, but I want you to just get that, the heart and spine are big with falls and potential C-spine injury, as well as electrical current and heart rhythm. An 80-kilogram man was electrocuted with 440 volts of electrical current upon arrival to the healthcare facility. So this happened at 8, but he arrives at the healthcare facility at 10. The emergency department physician determines that the burn is at 22%. So how much IV fluid per hour should be infused? So round off to the whole number. So what is the answer? Well, the answer is C, 587. So let's get where I got that value to make sure that this is information you need to know. So we know that, of course, fluid resuscitation is very, very important whenever a patient has a burn. And fluid resuscitation clock starts at the time of the injury, not at the time of the patient's arrival. So if the burn occurred at 8, but the patient arrived at 10, that means half of the fluid that is needed in the first 8 hours now has to be infused in 6 hours because the patient arrived in a kind of a lengthy time frame. The other thing where I got this number is that remember that the electrical burn formula is changed. It is 4 mils per kilogram, whereas other burns are all 2 mils per kilogram times the total body surface area. So, I'm thinking this is a specific number. It's different, which makes it kind of fodder for the exam. So that's why I've presented this to you. So let's look at the total calculation. We have 4 mils because it's an electrical burn per kilogram at 80 kilograms, and then times 22 because that's the original body surface area burn. So in the first 24 hours, this patient will need 7,040 mils of fluid. In the first 8 hours, the the patient should receive 3,520 because we divide the total by 2, because half of the total infusion should be given in the first 8 hours. Now we want to further do the 3,520. That's supposed to be in 8 hours. We know that the patient arrived 2 hours behind our schedule, and so therefore the patient's 3,520 mils has to be delivered quicker, and we need to get it in 6 hours. So that's where I came up with 587 mils per hour is what the adjusted IV per hour is going to be for the patient that arrives late behind that schedule. A man was electrocuted with 440 volts of electrical current, and an entry wound is noted in the left large exit on the sole of his right foot. After admission to the critical care unit, the nurse observes that the urine's brownish and a specimen is sent to the laboratory. So what intervention is anticipated? And the answer is A, rapid IV and fluid administration. So when we look at the whole scenario, we see that the entry wound is in the left and the exit's on the right foot, which means that the current likely passed through a lot of tissue, a lot of muscle tissue. And when that muscle is damaged by the electrical current, then the muscle will break down. It's known as rhabdomyolysis. And the muscle will break down, and what's released is myoglobin. Now, myoglobin is a large protein molecule that has to be removed through the kidneys, and it's kind of like a big pebble having to go through a very small stream. And the way to get that pebble out and downstream is to give a lot of IV fluids. There is nothing in this scenario that said that the patient has kidney failure. We know that myoglobinuria has the potential for causing kidney failure, but there's nothing to suggest that we're there. We do know that the patient has myoglobinuria because of the description of the urine. It's brownish. It almost can look reddish too, like it's blood, but that's the myoglobin. Furosemide is not necessary at this point either, nor is a dobutamine drip. What prevents injury is lots and lots of fluid being delivered in the IV, so it's rapid fluid administration. And in fact, your notes say rapid fluid administration till you get clear urine. This is just kind of the reminder slide for what the scenario is and the complications that occur to the renal system with burn trauma. There are some more burn questions that can be found in the Saunders NCLEX RN review book. Again, if you want to know more, if you want to excel, then study these questions. Otherwise, I really feel that you're adequately prepared for the burn questions if you read the notes and do these practice questions. I hope this has been helpful. Email me if you have any questions or disagree with any of the answers.